Aloha and welcome back to week one's lecture. This is part 2 of clinical exercise testing and interpretation for cardiovascular health. So when we speak about indications, why would somebody get a clinical exercise test or be told to get one? So we're talking about maximal here. So primarily for diagnosis, presence of disease or an abnormal physiological response, and that's clearly the most common indication. In the States, when you turn 50, males are basically told, take an aspirin a day and go and get a stress test. Can be done for prognosis. So what's the risk of having an adverse event? It can be for an evaluation of physiological response to exercise, blood pressure, heart rate, VO2 max, etc. But for AEPs, if you get a patient that comes in through your door and just say, oh, by the way, if you had exercise test recently, if they had, get a copy. It's invaluable for their exercise prescription. The reason being that it will tell you what their max heart rate was. So none of this 220 minus age stuff. You'll actually know what their max heart rate was, but also you'll know what their maximal fitness capacity was, their predicted VO2 max. If you're working in a practice that's near a hospital, or you get patients that are coming out of cardiac rehab like phase 1 or 2 in a hospital, a lot of programs do stress testing on their patients in and out of the program. Make sure you get that, because again, it's absolutely invaluable. So what are the indications? So as I mentioned before, detection of coronary artery disease in patient, evaluation of the anatomic and functional severity of coronary artery disease. And when it says anatomic, it's basically which coronary vessel, right main coronary, left main coronary, circumflex are the three major ones, and the severity. So evaluation of physical capacity and effort tolerance, evaluation of exercise-related symptoms. Somebody goes, oh, I get breathless walking up a hill, etc. Assessment of chronotropic competence, arrhythmias in a response to any implanted device therapy, and also any medical interventions. If somebody's got an exaggerated blood pressure response, you can check it at rest. But if they're people that exercise, you'll want to do a stress test to make sure that they've got now a normal blood pressure response. So what else? So current evidence does not support the routine use of a clinical exercise test to screen for cardiovascular disease in patients who have a low or very low pretest probability. And it's not supported in people that have a very high pretest probability, because basically they've got it. If anything, send them for an angiogram, because the likelihood of something happening sinister, if they have a very high likelihood of disease, is much higher. So class 1, the indication, so definitely appropriate. So these are the majority of patients. They're adults with intermediate pretest probability based on age, gender, family history, symptoms, etc., etc. Class 2, probably appropriate, and basically there's conflicting evidence or opinion on whether a clinical stress test will be helpful in diagnosing coronary artery disease. So class 2 may be appropriate. So if patients have a high test probability or if they have a low test probability. I know that contradicts what they've said before, that you don't need to do it, but if you get a conservative cardiologist, they may say, no, we want to have a test done. So class 3, not appropriate. So the problem with certain arrhythmias, like WPW, Wolf, Parkinson, White, if they've got an electronically paced ventricular rhythm, or they've got bundle branch block, it's not going to give a true test, a true result. So there's low sensitivity and specificity, and we'll talk about those. So contradictions. So there's 2 types of contradictions, and they're either absolute or relative. So a graded exercise test, maximal or submaximal, is never performed in the presence of an absolute contraindication, and you'll have to memorize these. Relative contraindications call for the individualized assessment of the risk. Does the benefit of the information obtained from conducting the test outweigh the risk? And if it does, then basically the relative contraindication may be disregarded. So what are the absolute contraindications? And you'll commit these to memory. Have they had an acute myocardial infarction within 2 days? Do they have unstable angina? Any uncontrolled cardiac arrhythmias, aortic stenosis, congestive heart failure, pulmonary embolus, or myocarditis? I'm just going to go back to that unstable angina. For you also, it should be on here I took this straight from ACSM, but also exertional angina. So if somebody's exercising and they come to you and they say, oh, it only happens at a higher intensity exercise, they still need to see a cardiologist and you get a referral. Can those people exercise? Absolutely. Do they derive a great benefit from it? Yes. Are they at increased risk? Absolutely. So what will happen is the cardiologist will do a stress test in their practice. They'll give you that rate pressure product, and basically what you're going to look for is what's the heart rate that it came on at. And you'll learn this in one of the later lectures, and you'll drop the heart rate by 20 beats per minute. So if they did a test and it came on at 150, your patient is going to use a heart rate monitor or an ECG, and they're only going to exercise 130 max. So what about relative contraindications? So if they've got coronary stenosis, stenotic valvular disease, you'll learn about that when we go over valvular disease, tachycardia with uncontrolled ventricular rate. If they've got a complete heart block, that's third degree AV block. If they've had a recent stroke or a transischemic attack, any mental impairment that they don't understand what they're doing, if their blood pressure is elevated, so either 200 or higher of systolic or 110 millimeters of diastolic, or if they're anemic, they've got an electrolyte imbalance or hypothyroidism. So let's talk about sensitivity and specificity because you need to know this. So the definition, sensitivity is the proportion of patients with disease who test positive. So 100% means that there's a test that every person that has that disorder, the test says they have it, okay? And that's called a true positive. Specificity is people that don't have the disease and the test says they don't have it, meaning they test negative. So 100% means that specificity is that the test says you don't have coronary heart disease, and it's a true negative. So let me give you an example of a test that was a false negative. So I'm in cardiology, and it's a separate ward at Lidcombe Hospital. I'm a research fellow there. I was on my postdoc, and then they hired me on as a research fellow. We did some work with nuclear medicine, which was in the main building, the main hospital building at Lidcombe Hospital. And somebody had gone in and they got a nuclear stress test, basically. The guy was negative, and the nuclear medicine was on the second floor. He walked down like a really nice kind of spiral staircase under a cupboard where cars can pull up and, you know, pick people up, drop them off. And he just fell over and carked it, you know, and he just had a test that said he was free of disease. So he had a false negative test. So what causes false negatives? So one of the biggest ones is an inability to get the heart rate up high enough. And resultant to that is they don't reach an ischemic threshold, or you're not monitoring a number of leads to detect any ECG changes. That's why we teach you 12-lead ECG. Failure to recognize ECG signs and symptoms that may be associated with underlying disease like exertional hypotension. If they've got angiographically significant cardiovascular disease that's compensated by collateral circulation. So collateral circulation, we'll just draw the heart and put this up so you can see it. And let's just draw, that's the main, that's the circumflex, and that's the right. Let's see how this is going to work. Yep, anyhow, if one of those becomes occluded, you actually end up getting new collateral circulation that helps perfuse the myocardium. So any musculoskeletal limitations to exercise preceding cardiac abnormalities, technical or observer error, or basically cardiovascular disease, an ECG, or etc. Now, moving on. So when you do a stress test, submax, maximal, whatever, you can look at this. It works better for somebody who's had a max test. And basically what you do is, it's called FAI, functional aerobic impairment. And you take their predicted VO2 max minus the observed over the predicted. And that's going to give you a percent. And the higher the percentage, the greater the functional aerobic impairment. So you can see there, up to 40% is mild, 54 moderate, marked, and severe. So what about stress testing in children? So in Sydney, we had the Children's Hospital, and we used to get our students that would get practicum there. And it's unusual to basically do stress testing in children, but it is done. So if they're generally getting evaluated for their exercise capacity, but it can also be for coronary heart disease or induced arrhythmias. So basically up here, I had a mother bring in her 14-year-old son, and he just couldn't do the training that was required for Aussie rules. Basically, his VO2 was low, but I did some subsequent strength testing on his legs, and he just had really, really low leg strength tests. So basically, the problem was his legs weren't strong enough and powerful enough to keep up with the training. So he basically just needed, the recommendation was, look, get him an AEP who can do strength training and power training, and that should improve it. So one thing too is, remember that 220 minus age is not valid for children, age 10 to 16. So they recommend an equation, and this is by Mikado, 2011, 208 minus 0.7 times age. Now, there is a heap of graded exercise testing protocols. So we're just going to go over some basics now on that. So look at all these different protocols, and what they've done, here's the minutes of time and METs. So remember, if you multiply METs times 3.5, it'll give you VO2 in mils per kg per minute. So if we look at these different protocols, you can see based on that. So for example, this purple one is, which one? That's probably Bruce. I'm just guessing based on it. But in principle, you can see that it starts at the highest MET level and obviously goes the highest. So if you're testing somebody who's particularly frail and they're not fit whatsoever, you might be thinking, I'm just going to do a 6-minute walk test. Can you test them on the treadmill? Absolutely. Is the Bruce going to be the most appropriate? No, you're probably going to think either a Naughton or a modified Bruce for sure. So these are the protocols when you're in practicum and you're in the SCU Health Clinic, both in Lismore or here at the Gold Coast. I've printed these out and laminated them for you, but you should keep these in your own booklet of things that you'll take out into the world when you graduate. So this is the Bruce protocol. It starts at 10%. Speed and grade go up every 3 minutes. Modified Bruce, still 3-minute stages, but notice the gradient for the first couple stages, and the speed is much slower. And then you get the Naughton, which is even a much more, which is a lower one, and only 2-minute stages each. So which protocol do you use? We'll talk about that more when we have our PBL in week 1. So graded exercise testing in children, again, it's very unlikely that you'll do any testing, but if not, the Cornell, McNaughton, bulky, because they have a slower increase in workload. If the kid's fit, etc., you could use a Bruce. If you're on a cycle ergometer, the McMaster protocol, the James protocol, Godfrey, or any continuous ramp protocol. A continuous ramp protocol is something like what we do with athletes, where every 30 seconds you increase them by, 20 watts, etc., until volitional fatigue. So what about indications for terminating a symptom-limited maximal exercise test? So they're on the treadmill, you're doing a submax in this example. So remember, the rules that apply for maximal testing, you're going to use and follow for a submax test. For example, you're doing your OSCE and your patient is one of the things on the first page. Let me see which page. On page on one of the early pages, you'll have to do resting heart rate. You'll take the heart rate and you'll report whether it's regular or irregular, etc. And next thing you do is calculate 85% of their age predicted max, because that's all you're going to do. Let's say during the OSCE, the person's age predicted max is 140. They hit 140, 142, and you're going to stop it, that's fine. If you then increase the speed and grade and you're going to do another one where you know their heart rate is going to go up by a lot more, you've just failed your OSCE. So it's really important, 85%, and I can't stress enough, do not do maximal exercise testing when you're out in practice. So what are the absolute contraindications? Any change in ST segment elevation, so 1 millimeter, if blood pressure drops by 10 millimeters, systolic blood pressure drops by 10 millimeters with an increase in workload, if the person complains of any chest pain or angina, any nervous system issues, ataxia, dizziness, near syncope, poor perfusion, if they've got sustained ventricular tachycardia or any other arrhythmias. Let's pause there for a second. Sorry, I just fixed that typo. VTAC, ventricular tachycardia, or any other arrhythmias like second or third degree block. If the ECG system fails or the patient requests to stop. So my master's degree is in clinical exercise testing and cardiac rehabilitation. And when we had the clinical exercise testing unit of study in ECG, we had to do like a mini OSCE, what you're going to do, but we had to do it one-on-one with a real patient. And what the instructor did is basically told the patient at a certain point during the ECG to take the ground lead off, just to pull it off. And basically that shuts the ECG system down. God forbid if you kept going with the test because he failed you straight away on that. And the last one, obviously, if the patient requests to stop, and that's volitional exhaustion. What are relative indications? So if there's horizontal or downsloping ST segment changes of 2 millimeters or more, if there's a drop in systolic blood pressure with increasing workload, again, chest pain, fatigue, shortness of breath, wheezing, leg cramps, claudication, any arrhythmias, multifocal PVCs or bradycardic response, or an exaggerated blood pressure response, 250 over 115, if they've got a bundle branch block, or if their SpO2 is 80% or less. Now that's ACSM guidelines. Note here, we use 90% as the cutoff for terminating either exercise or a submaximal exercise test. So somebody does an exercise test, maximal, submaximal, whatever. There's 3 outcomes from it. Negative outcome, that's a good thing. Test is negative for ischemic changes, chest pain, arrhythmias, hemodynamics, blah, blah, blah. They've had a normal response to exercise. Positive, not good. It's positive for ischemic changes, chest pains, arrhythmias, or hemodynamics. And then the last one, which is unequivocal, meaning it doesn't rule out or rule in coronary artery disease. And basically from this, guaranteed the patient's going to go on and they're going to get an angiogram. So subsequent testing. So what outcomes do you report from a stress test? So why are you doing it? Generally here, when you type into the Xscribe system, it's going to be initial fitness assessment. What protocol did you use? Bike, treadmill, and what was the protocol? You're going to do your resting exercise, post-exercise, ECG, heart rate, blood pressure, etc. Any deviation from their last clinical assessment. So let's say you're doing a retest, and did the person improve? What's their predicted VO2 peak? And their category, good, bad, average, etc. And the recommendations for their exercise prescription and any specific limitations. So, and we'll talk about your report in the PBL discussion. What else? Resting and peak heart rate and blood pressure, rate pressure product. Why was the test terminated? if and when anything significant develop, ST segment changes, chest pain or any symptoms, any arrhythmias, even if they're ectopics, any symptoms that they may have mentioned. So next week we'll talk about ECG placement. There's a link to review that, ECG interpretation. So mahalo, thank you very much. This concludes your lecture for week 1. I'll stop now and I'll upload it to Blackboard for you.